Thank you so much. Thank you, Dr. Silvati. Today, I want to talk about how to maximize success in immediate implants, and because there are many, many points that I want to try to just talk about them in this presentation, so I straightly go to the main point of my lectures. Speaking of predictability and speaking of maximizing success, our main concern in immediate implants are these two things. Number one, losing the papilla. Number two, midfacial recessions. And when we want to maximize the aesthetic, when we want to prevent the complications, these are the things that we are looking for. So first, let's talk about the survivals. Is the survival of conventional implants is the same as immediate implants? For answering that question, I want to refer to you to two famous systematic reviews, one by Ronald Young in 2008, and he showed that the 5-year survival of conventional implants is almost about 97%. And if you look at this is the systematic review by Nicholas Peter Lang in 2012 on immediate implants, again, the number on survivals on 4 years is about 97%. So speaking of reliable and predictable treatments, we can say that according to the evidences that we have, they can be comparable according to the survival rates. And according to this literature, we saw that there is no difference between the maxilla and the mandible and no difference between the posterior and anterior. So if we stick to the techniques, to the principles, it can be successful. According to another study by Marco Esposito in 2010 by the Cochrane database, they showed that the aesthetic outcome might be better in immediate implants if we do the provisionals, because we can save the shape of the tissue. But speaking of predictability, they mentioned that maybe immediate implants be at a higher risk of failure. But it's maybe, it's not definite. And this is a study by Barry Wagenberg and Stuart Forum. They evaluated almost 2,000 implants with up to 16 years of follow-up. And they showed that the failure rate in the posterior part of the maxilla, which we usually have the more occlusal forces and less bone density, is only about 2 to 3%, which reflects the predictability and survival of about 97 to 98%. So we can say that immediates can be predictable. But if we focus on immediate anterior implants, we also have the same things. The studies by Peter Worley, by Joe Kahn, by Edgar Elchar, you can see the 90% on 206 implants, or Uli Grunder, you can see all of them have showed a great survival rate, almost 97%. And in most of these studies, they mentioned that the most critical factors influencing the success and survival was primary stability. So it's very important to be able to gain a good primary stability while we are inserting our dental implant. So let's watch these microstructures of different dental implants. I'm not going to say this because it's Megagen or whatever, but for achieving the primary stability, it's very important to be able to gain bone between the threads, to stock the bone between the threads, to have sharp edges on the threads. And I'm not going to say which one is this, which one is that, but you can guess in which system, in which design, no matter what's the name, what's the brand, you can gain better primary stability, especially in extraction sockets. Because we need a little amount of bone, we have a little amount of bone to be able to gain the stability. So, till now, about anterior immediate implants, you can see that the survival rate is almost comparable to conventional implants. You can see that it's more clinical, condensed procedure, fewer appointments, patient is happier, doctor is happier, but most importantly, we can preserve the tissue if we do the provisionals. So question number one, do immediate implants prevent bone loss? Is it true or not? Well, the answer is what? A big no. Implants cannot prevent the bone loss. Why? Because when you extract the tooth, you're eliminating PDL. And we have a specific part of the bone that we call it the bundle bone. And it's PDL dependent. So when you extract the tooth, you will lose that part of bone. So we cannot say that immediate implants can save all part of the bone. So because we're going to lose PDL. Implants do not alter bone modeling and remodeling. Next question, Do immediate implants increase the risk of labial bone loss? That's another question, completely opposite. In 2005, there was a study by Maurizio Aruju and Jan Linde's group, and they did this dog model study. They inserted implants into the sockets, and they faced lots of bone loss after implantation in 6 months, in 12 months, and even in 2 years. And in that period of time, everybody said that immediates are risky, please don't do it, blah, blah, blah. In 2009, Van der Wagens showed the same thing, almost 3.94 millimeters of collapse buccopalatally after immediate implants, and there was a guard for immediates. But when you read articles, you should be clever and see what were their criteria. For example, in all these articles, they used wide implants. They all put the implants in contact with the buccal bone. Implants were not platform switch, and they all reflected the flap. So can any of these factors have an influence on the outcome that we're gonna gain? We need to answer that through this presentation. Can we minimize the loss? 9 critical factors to affect, I'm gonna just name them for you. Number 1 is facial plate thickness. According to Vivian Capius' work, it's Danny Boozer's group in Switzerland, they showed that if the bone is thin, then the dimensional changes of the ridge is significantly more comparing to the one that the bone is thick. So thickness of the buccal bone is a critical factor that can have an influence on the outcome. Also, according to this study by George Ferrus, you can see that when the socket wall thickness is less than 1 millimeters, you will see significantly more bone loss. But now the question is this: how thick is your buccal plate? We know that 1 millimeter is critical, but how thick is that? We have tons of studies showing this and proving this, but this is one of the most famous one by Guy Heimba and Mariano Sanz from Spain. They extracted 75 maxillary anterior teeth, they reflected the flap, and they measured the thickness of the buccal bone with caliper. And they showed that in more than 80% of the cases, the thickness of the buccal bone is less than 1. So we know that we need to have more than 1 millimeters of thickness, but in more than 80% of the cases, the thickness of the buccal bone is less than 1. Now, what is the blood supply to that piece of bone? Number 1 is periodontal ligament, but we said that it's tooth dependent. So when you extract the tooth, bye-bye PDL. Number 2 is the underlying bone, the spongineous bone between 2 cortical layers. Now, how thick should be the bone to have a spongineous bone in between? Minimum 1, 2, 3. Minimum, it should be 2. But as you saw, in more than 80% of the cases, the thickness of the buccal bone is less than 1. So we cannot count on factor number 2, or supply number 2. What is number 3, the last one? Periosteum. So what will happen with this? Number 2 is facial flap reflection, which deals with the periosteum. What if we reflect the flap? What will happen? These are the studies that have reflected the flap, everything else was perfect, and you can see the dimensional changes buccopalatally. You can see it can be between 2.6 to almost 6 millimeters of collapse just by reflecting the flap in the hands of experienced surgeons. What if we don't reflect the flap? This is studies by Ulle Grunder, by Lyndon Cooper, by Marco De Guidi, Dennis Tarnow. You can see the changes. 0.1 to maximum 1. It's not 2, it's not 3, it's not 4, it's not 5. Maximum 1 millimeters. So this is the importance of the periosteum, and you can see the studies by Manuel Chanavaz from France that the effect of the periosteum been measured on bone remodeling and bone resorption, and also this is a study by William Seliger that have shown the vascular interconnection between the bone and the periosteum through the PDL. So we have aesthetic risks: thin bone, which we talked about it, and also thin tissue, which I'm going to talk about it later. So speaking of extraction sockets, we have 3 types. In type 1, this is one of the most simplified classification by Nicholas Ilian and Dennis Tarnow. In class 1, soft tissue is there, bone is there. So it's the best choice for immediate implants. In type 2, you have the tissue, but bone is gone. And in type 3, no bone, and no tissue. So definitely, we think that these two cases are not appropriate for predictable immediate implantation. Factor number 3, which is the type 2 sockets, facial plate dehiscence. What if we place our dental implants immediately at the presence of the dehiscences? You can see studies by Pascal Valentini, by Steve Chen, or Joseph Kahn, all have shown the same thing. If you place your implants immediately at the presence of the dehiscences, comparing to the presence of the thick buccal bone, you will face more recessions, more failures, less bone fill, and more horizontal bone loss. So, do you want to be predictable? Definitely you want. So, our choice will be the presence of the buccal plate, and even better, the presence of the thick buccal bone, not the thin buccal bone. Even in the hand of experienced surgeons like Dennis Tarnow, when they did like the ice cream cone technique with rigid membranes without reflecting the flap to try to build that lost bone, they faced about 1.3 millimeters of collapse during the immediate implantation. So maybe it's better for type 2 sockets to get involved with the Danny Boozer concepts and going with the early implantation and do the contour augmentation instead of putting our implants immediately if we want to be predictable as much as possible. Number 4, implant positioning. In the first slide, this is a study by Marco Caneva. I want to talk about the diameter of the implant, narrow, standard, or wide. They showed that standard diameter implants showed significantly less resorption comparing to wide implants in contact with the buccal bone in immediate extraction sockets. So we don't want to place our implant in contact with the buccal bone. That's an important piece. Number 2, in another study in the same year, in 2010, according to the position of the dental implant, they showed that in extraction sockets, it's better to place our implants 1 millimeter deeper, according to the buccal plate, and also a little bit to the palate, relating to the center of the socket. But how many millimeters to the palate? If you want to have an exact number, this is a study by Cristiano Tomasi, and he described it very beautifully in this diagram, but I just want to summarize it for you. They showed that if you have this contour for the buccal and lingual plate, and if this is the center of the socket, if you place your implants immediately in the center, you will face bone loss. But if you want to minimize this, it's better to go 1 millimeter deeper and 2 millimeters palatally from the center of the socket, which will be usually the functional cusp position. In the anteriors, it's cingulum. In the posteriors, it's the buccal slope of the palatal cusp. In the posterior part of the mandible is the lingual slope of the buccal cusp. And in the lower anteriors, it's usually under the incisal edge. According to factors influencing the recessions with midfacial recessions, which I presented, that is one of the most concerns for dentists in immediate implants, they showed that facially positioned implants will cause significantly more bone loss. And in this review by John Cossine in 2011, he showed that the most important factor that can influence the midfacial recession was facially positioned shoulder of the implant with the odds ratio of 17.2. This was the leading problem for midfacial recessions. So we don't want to place our implant in a bad direction. It should be exactly in a functional cusp position to prevent the complications. We don't want to end up like this. We want to be predictable because most of the time these cases cannot be manageable. Number 5, the depth of placement of dental implants. Should it be placed from the crest of the bone or should it be placed from the gingival margins? How should we measure the depth of implant placement? We have a rule by Lyndon Cooper from University of North Carolina, 3A, 2B rule. And also it's been mentioned by Fernando Vizcaya during the years. And what is 3, what is 2? We need to have 2 millimeter labial plate thickness for predictable outcomes, for make sure that the bone will stay during the years. And also, we need to have 3 millimeters space for the biological width formation and for emergence profile, for the running room, for the prosthesis. If we don't have enough tissue, we're going to face the bone loss because biological width always exists. So we need to provide the space for it. If we don't, body itself will provide the space. And if the body provides the space, the result will be the bone loss and exposure of the threads or the color of the abutments. So you can see these two cases. Sometimes the reflective flap, we see good amount of bone, and we are happy and place our implants. But we don't take it into the consideration that where is the tissue? How can I shape the crown? What should we do? So it's very important to be able to provide that space because we need to have a space for biological width. Number 6 is the horizontal gap management. We said that for being predictable, we should place our implant not in the center, but also a bit to the palatal and not to be in contact with the buccal bone. So what will happen to that space? Should I graft the gap? Should I leave it there? What will happen? Will the soft tissue go in there? This is the famous study by, it's a human histological study. I really like this study, by Dennis Tarnow and Steve Chu. It was published in 2011 in Ron Nevin's journal, Journal of Perio and Restorative Dentistry. There was a 65-year-old man. There was an implant in the area of the canine. They extracted the tooth. They placed the implant. And you can see the gap was about 4.3 to 4.5 millimeters. And they did nothing. They let it heal. This is 1 week. This is 9 weeks. The million-dollar question, what is underneath? What is in contact with the dental implant? Is it soft tissue? Is it bone? Is it nothing? That's the question. They explanted that dental implant with the permission of the patient to answer this question. And they usually present it in this topic. And you can see bone up to the first thread. There is no soft tissue there. There is no way for the soft tissue to migrate through the gap. Why? Because here we have clot. And clot is dead. It's not vital. So there is no way for the soft tissue to migrate through a dead piece. So first, we should have young connective tissue forming from the walls of the socket, and then epithelium can migrate on top. And that's the reason we don't have any concern for the soft tissue to go in. Because if it was like that, after any extractions, instead of bone formation, we should have faced soft tissue formation in the socket, but it won't happen. And also you can see the studies by Ernesto Lee that they showed that if you graft the gap, the dimensional changes was only about 0.1, almost 0. It was a CBCT evaluation in this study. Because the point for us was not enhancing the bone formation. The point for us was preventing the collapse. We should augment the gap to increase the buccal bone thickness to prevent the collapse of the tissue, not because we have concern for migration of the soft tissue into the gap. So can we minimize the loss? Can we minimize this to this? Yes, we can. We should graft the gap. Number 7 is immediate provisionalization. Should we put a provisional in immediate implants into the extraction sockets? Should we provisionalize the case? I told you, all teeth have the biological width. Can anyone in this hall show me their bone? Can you show me your bone? Let me see your bone. You say, oh, it's white, it's very smooth, you can touch it. No, you cannot show me your bone. Why? Because bone always covers itself with what? With periosteum. Now, can you show me your periosteum? Look, this tiny layer of tissue and this, you can touch it. No, you cannot. Why? Because periosteum always covers itself with what? With connective tissue. Now, can you show me your connective tissue? No. Why? Because connective tissue always covers itself with what? With epithelium. So epithelium, connective tissue, and periosteum are compartments that always cover the bone, and they should have a minimum amount of thickness, and it's usually 2 millimeters. And then we don't have any tooth or any implants without sulcus. So we need to have at least 1 millimeter depth of sulcus. And that shows that you need to have 3 millimeters of tissue on top of your implants if you want to be predictable. And in cases of extraction sockets, you have that height, but you need to save it. If you do nothing, you will face the collapse. You will lose the papilla, and it's even more difficult to build the papilla again. So it's better to preserve it if it's possible. According to this study by Tor Berglund in 1996 Journal of Clinical Periodontology, you can see that in cases that they had less than 2 millimeters of tissue, they lost the bone. Why? Because of the biological width. But in cases that they have 4 millimeters tissue height, the bone was saved. This is the same thing that Thomas Linkevicius showed as zero bone loss concept. I will talk about it a little bit later. So we need to have this space. We need to have this space for the running room, for the biological width, and for the aesthetics. Now, I talked about grafting the gap, I talked about provisional restorations, I talked about doing nothing, and what's the comparison between them? For answering that, I want to refer you to this study by Salamas and Dennis Tarnow, Steve Chu, and also Hanay Saidov from University of Maryland. It is the part 1 of this study. They had 4 treatment groups. In group 1, they did nothing, no bone graft, no provisionals. In group 2, they put provisional but no bone graft. In group 3, they put bone graft in the gap but no provisional. And in group 4, the whole package was there. They did the graft in the gap, and also they put the provisional. What was the differences according to the dimensional changes? You can see in the control group, in this area, which is the bone changes, this is the soft tissue, this is the bone, you can see the changes was about 1, 1.1, or something like that. In the cases that they put the provisional restorations, the changes was about 0.7 or 0.6. In groups that they put bone grafts in the gap only, the changes was about 0.3, 0.4. And the groups that they did everything, the changes was almost 0. So speaking of collapse of the bone, bone grafting is really important. But speaking of collapsing the tissue, provisionals will make the main role. So in cases that we want to do the extractions, it's very important first to do the extractions atraumatically. First do the evaluation. If the bone is there, leave it there. Don't reflect the flap just because you want to see what is underneath. Because I told you, if you reflect the flap, you're cutting the vascular supply, and definitely a specific amount of bone remodeling will happen, and that will cause the changes. We should place our implants in a correct position. We should do the graft the gap. We should do the provisionals and try to save the shape of the tissue with the provisional. And after 5 to 6 months, come back for the final crown. Number 8 is the presence of the interproximal bone. What's the importance of that? According to this study by Ule Grunder in 2000, they showed that the papilla height between a tooth and implant can be about 4.2 to 4.3 millimeters. It's not 5 millimeters comparing to what we have between 2 teeth. And the most critical factors that can influence the presence of the papilla is the presence of the interproximal bone. So before extraction, you should be careful. If the interproximal bone is there, if it's not, there is more possibility to lose the papilla. So you should think about it, and you should be more cautious for the treatment. But, for example, in such cases, if we have the interproximal bone, can we be sure to save the papilla in the future? Is the presence of the interproximal bone itself is enough? The answer is no. Why? According to this study by Marco Esposito in 1993, he showed that if you put your implants too close to the teeth, then you will lose the bone. Why? Because we have biological width 3-dimensionally all around. It's not only from the buccal, it's not only from the palatal. We have it all around. So I have the interproximal bone, I have the interproximal bone. If I place my implants in the middle, it's okay. But if I get too close to this bone, the biological width will form, and I will lose that bone. So the positioning is also important. Only having the interproximal bone is not enough, but we need to have it, and then we need to place our implant in a correct position. So sometimes we extract one tooth, and we have interproximal bone, everything is perfect. But if we extract 2 teeth, then we're going to lose the interproximal bone in between, and there is more risk for losing the papilla. Then what should we do? You can see that between an implant and tooth, we can have about 4 millimeters or 4.5 millimeters of tissue height. named as a papilla. But between two implants, this height can be only about 3 and 3.5, or maybe 3 millimeters. It's not more than that. Why? Because between tooth and implants, we have supracrystal fiber attachment to the cementum. But between two implants, we don't have any cementum. So there is no possibility to save the height of the papilla. So what will happen? Subcrystal biological width formation. Can we minimize it? According to this study by Dennis Tarnow's group, they showed that you need to have 3 millimeters of space between two implants, two conventional implants, to be able to save the height of the papilla. Why 3 millimeters? Because the width of the biological width is about 1.5 millimeters on each implant or on each teeth. So 1.5 and 1.5 will be 3. If it will be less than 3, we will lose the interproximal bone, and when the bone is gone, tissue is gone, because tissue follow the bone. But sometimes we don't have that space. What can we do? In those cases, platform switch implants can be a solution. Those implants with more narrow necks can be a solution, and we can just be able to insert our implants by decreasing the amount of biological width formation, place our implants a little bit closer to each other. You can see this in studies in implants without platform switching and in implants with platform switchings. We can have a space for soft tissue. This is a non-platform switch implant, and if you place the abutment collar, or if it's a tissue level implants, if you place it inside the bone here, you will lose the bone, because bone will not attach to a polished surface. But imagine if you place an implant with the platform switching. In this space, instead of this, you will have tissue. And that tissue will play a role in saving the bone and preventing the bone loss and more space for the biological width. And according to this study by Luigi Canulu, this is the human study with the 33 months of follow-up, he showed that the more the platform switching, the more the body is able to save the crest of the bone. But the question is, can platform switching always save the bone? Can I make sure that, okay, my implant is platform switching, I'm happy, let's go and save the bone and make sure that the tissue will not lose? The answer is no. How to answer that question? The last one, factor number 9, which is the soft tissue thickness. How many people measure the thickness of the tissue before placing the implants after the incision? This is the most critical factor, and I brought it at the end. Because if you don't have tissue thickness, you will have nothing. This is the thing that can guarantee your work and guarantee the preservation of the bone long term. We have lots of studies. I mentioned here the studies by Thomas Linke, because he started this project in 2009 at EAO Monaco. He presented it, and you can see the follow-ups with conventional implants, with platform switch implants, and he showed that if the thickness of the tissue supracrystally is less than 2 millimeters, you cannot make sure that the bone will stay long term. And the reason is simple. It's biology. It's biological width formation. It's very simple. Also, we have confirmation in other studies like this one by Roriki, which she did this evaluation on overdentures and with different abutment heights, which reflects the different tissue thicknesses. And they showed that when the abutment heights are more, you have more tissue thickness and you have less bone loss, less crestal bone loss. So tissue thickness is very, very important. But the main point is this. According to all these studies, they showed that platform switching itself does not prevent crestal bone loss if the tissue is thin. Platform switching is good if the tissue is thick, not if the tissue is thin. So it's very important to take it into the considerations. Materials will not solve the problem. Biology is the main key. So tissue thickness is the first priority, and then we can just try to maximize the success by different developments and different technologies. So, what is the treatment strategies to maximizing success? Definitely narrow implants, providing more buccal bone thickness if possible. In cases like any ridge implants, you can see that you have the same core, like 3.3, but the thread depths will increase. So instead of removing the bone, you are saving bone between the threads. And that's the key. Do you prefer, for example, for placing a 5mm implant, remove a 5mm core of bone, or remove only 3mm but insert a 5mm implant? Instead of removing the bone, saving the bone between the threads. More primary stability and more bone around your implants. Definitely that will be the choice. According to Grunder in 2011, soft tissue thickness buccally also can prevent the bone loss. And according to Danny Boozer, if you have dehiscences, delayed approach and contour augmentation can be a better option. And according to Kawani, placing implants deeper and more palatally can again increase the success of your treatment. If you see this case, this patient came, and you can see that there is no buccal bone. Here we have a defect. Here is the fractured. This is a necrotic bone. This is not a recession. And after this extraction, you can see you have nothing. So we cannot do any reconstruction at the same time. Yeah. So first, try to build tissue. Even better is to let it heal and try to do the tissue graft 2 months later. Just let the Mother Nature connective tissue fill the area instead of doing many, many grafts. And after achieving good healing, then we don't have any bone. We need to reconstruct the bone. We have different techniques, but definitely having the rigid scaffold is one of our options. So something like titanium meshes, which we make us able to place it immediately on implants, will make our job easier, because after doing the soft tissue graft, we don't want to reflect the flap many, many times because it will again face recessions. So like these IgG membranes, we can be predictable in the amount of bone that we want to do the augmentation. And then achieving a good contour. The last key, don't put a wide healing abutment after doing the soft tissue grafts because we will lose the tissue. Try to go first with narrow abutments and then slowly, slowly, if you need it, try to expand it to preserve the height of the tissue. But why I put this case, it was for this last one. You can say that, it's not beautiful, right? Maybe some people say that. At first I said that. It is a provisional actually. But this patient didn't want to do anything with other teeth. Just wanted to replace this. So if you look at his teeth here, and if you look at this line, this is the CJ and this is it. And if you look at it here, it's almost the same. We have about 2 millimeters. Oh, this line is a little bit sloped, but we have about 2 millimeters difference. So we just gave the patient the same teeth that he had. Because the better treatment options maybe was to do the crown lengthening, to do the veneers, everything, and make it everything perfect. But the patient just lost one teeth and just want one tooth to be replaced exactly in the way that it was at first day. So, what is my conclusion? Under contour restoration is very important for the cases that by any error the implant is labial, because over contour restorations will cause recessions. Number two, if your implants are platform switching and if you are placing your implants more to the palate, it's recommended to place it a bit deeper to have enough space for emergence profile, to give the patient a natural appearance. We should mimic the tooth morphology and root cervix. Implant placement should be from the soft tissue margin, not from the bone margin, because we need to have soft tissue thickness on top of the implants. For emergence profile, no buccal bone, no implant, because we want to be predictable. It's not a rule, but it's recommended. And what about the flap? Definitely, if the bone is there, leave it there and don't disturb. Don't reflect the flap, because cutting the periosteum will cause the bone loss. With that said, I want to invite you all to the second International Symposium of Complications in Implant Dentistry in Tehran, and one of our main sponsors is Megagen. We have great speakers like my dear friends Ashraf Soaya and Raquel Zita from Megagen. They will be there, and Christian also. We will be very happy to be your host, and also I want to thank Megagen for inviting me to this event. It's always a such true honor, and we definitely miss Dr. Park. Wish to see you all soon again. Thank you.